Good morning or afternoon, everyone, depending on where you're joining us from today. I'm Harpa Isfeld-Kiely. I'm with the National Collaborating Center for Infectious Diseases, or NCCID for short, and I'm really happy to welcome you to our webinar today, the fifth in the CAN AMS webinar series. And today the topic is what CAN Antibiograms Tell Us, Microbiological Insights for Antimicrobial Stewardship. So I'll be introducing our speakers shortly, but first I'd like to start us off well with our land acknowledgement. I would first like to acknowledge that the National Collaborating Center for Infectious Diseases is hosted at the University of Manitoba, which is situated on the ancestral lands of the Anishinaabe, Anishinaabe, Dakota, Dene, Nehethawak, and Ininawak nations. It is also in the heart of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work and are committed to working with our partners toward reconciliation. We would also like to acknowledge the Indigenous peoples of all the lands that we are on today. While we meet today virtually on this platform, we would like to take a moment to acknowledge the importance of the land in which we each call home, and we do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. So I have a few housekeeping points. Attendees are all on mute, and that's to reduce distractions during the session. The chat box is disabled. We have it for our presenters only. However, for attendees, we ask you to enter your questions into the Q&A box, and you can do that at any time, but we will take questions only at the close of presentations. Upvoting is active, so you can upvote your favorite questions from others. Today's recording will be posted on the webinars page of AMR Aware Canada, and on the NCCID, or our handle is Center Infection on YouTube, on that YouTube account. It's under a playlist, also CAN AMS Antimicrobial Stewardship Webinars, if you want to find more. If you're having any technical difficulties during the session, please email Crystal. So her email is simply crystal with a K @me.ca. Next up, just to make you aware, as I said, this is the fifth in a series of webinars. They're co-hosted by the Association of Medical Microbiology and Infectious Diseases Canada. You'll know it as AMI Canada, and the National Collaborating Center for Infectious Diseases, NCCID. So the CAN AMS name is short for Canadian Antimicrobial Stewardship Webinars. We call it CAN AMS because we are really promoting what can be done to help slow the rise and spread of antimicrobial resistance, and that positive spin that we highlight some leading practices and how to implement evidence-based interventions, but also what can be done in lower resourced areas. So check back on AMR Aware Canada for coming events. The next slide just shows you, this is what the site looks like. We want to build a little bit of awareness and recognition for this website. It not only hosts a national campaign during World Antimicrobial Awareness Week in November, but it also hosts a list of resources for public, but also for healthcare providers and other audiences, and it hosts this webinar series. So on to the next, we have a poll for you. We'd like to hear from you about your thoughts on antibiograms. So how often do you use an antibiogram to support empirical antibiotic prescribing or the choice of antibiotic? Do you use it frequently, periodically, rarely, never, or maybe it's not applicable if you're not a clinician? So I'll have Crystal post the results. All right. Here we are. So yes, we see a lot of non-clinicians, but frequently and periodically are neck and neck. So we've got some good supporters for use of antibiograms here. We'll close that poll and go on to the next. So poll number 2, I'll ask next slide, yes. How important are antibiograms for the development of local therapeutic antimicrobial guidelines for common clinical infections? Are they critically important, like really key to consider? Are they somewhat important or should be considered in all developing local antibiograms? Are they useful, but maybe other priorities like national or international guidelines are more important, or they're not important at all? So I'll ask you to fill that poll in. Take a minute. And we're going to see the results. Critically important. Boy, we have a lot of great supporters for antibiograms here, but we'll be happy to have our speakers get into the weeds with us on some of these issues. So today we have with us our speakers, Dr. Terence Wuerz and Dr. Philippe Lagacé-Wiens. And I just want to introduce the two of them to our webinar and welcome them today. Dr. Terence Wuerz is an assistant professor in internal medicine in the section of infectious diseases and in the Department of Community Health Sciences at the University of Manitoba. Dr. Wuerz dedicates his research efforts to clinical infectious diseases, antimicrobial resistance, and optimal antimicrobial use. He has been lead investigator in national and international multi-site clinical trials, which explore therapeutic options for various infections, including S. aureus, C. difficile, and pneumonia. Dr. Wuerz is committed to enhancing medical care quality through prudent antimicrobial use and improved communication between healthcare providers and patients. In collaboration with NCCID, he leads the Manitoba AMR Alliance with an aim to raise awareness and provide clinical tools supporting antimicrobial stewardship in the province. Dr. Philippe Lagacé-Wiens is an assistant professor in the Department of Medical Microbiology and Infectious Diseases at the University of Manitoba and a medical microbiologist at the St. Boniface Hospital in Winnipeg. He has been active in national surveillance studies designed to assess the epidemiology and antimicrobial susceptibility patterns of bacterial pathogens in patients within the hospital setting, with a particular interest in multi-drug resistance in Enterobacterales. As a medical microbiologist, he is also actively researches diagnostic methods for infectious diseases. He has published widely on a variety of topics, including clinical microbiology and diagnostics, lab-acquired infections, antimicrobial resistance, novel antimicrobials, and tropical medicine. So I want to welcome you both to the webinar. Terry, Philippe, I'll join you again for the Q&A, but for now, please take it from here, and we'll stop sharing these intro slides.
Oh, thanks very much, Harpa. I just wanted to make sure that you can see my my slide okay?
Yes, we can.
Perfect. So thanks again, and it's great to be here and have such a large audience to talk about antibiograms. Neither of us have any particular financial disclosures. So for today, we'll be talking about antibiograms, and in particular, we're hoping that you'll have a greater awareness of how antibiograms are produced, an understanding of how clinicians can incorporate antibiogram data in forming clinical decisions at the bedside, and an improved knowledge of the limitations that we need to consider when we're interpreting antibiograms. So I'm going to start us off with a clinical case, and then I'll come back to it at the end of our session. So Bernadette is a fictional case, but one that is very commonly seen in our hospitals these days. She's an 80-year-old woman. She does have a history of recurrent urinary tract infections and also has a previous history of a sulfa allergy that was Stevens-Johnson syndrome, so quite a severe cutaneous adverse reaction. She's in the emergency department. She has fever, chills, nausea, and flank pain. And you can see that she has an elevated temperature, but an okay blood pressure and heart rate. She has some right-sided costovertebral angle tenderness, but she doesn't look toxic. And her white blood cell count is elevated. Urinalysis shows pyuria and positive nitrite test. So she's suspected to have a right-sided pyelonephritis, which I think is relatively non-controversial. She's prescribed oral ciprofloxacin and sent home under the care of her family. The next day, she's called back, however, by the emergency room physician, as both her blood and urine cultures are positive for E. coli growth, and the susceptibilities are pending at this time. So she states she's actually feeling worse. She has ongoing nausea, minimal oral intake. She's had some rigors overnight, ongoing fevers, and so she was advised to come back to the ER. And I wanted to note that this case is from the website Manitoba AMR Alliance, which is a website that I lead with NCCID that has a number of resources on it, including learning cases. This is one of them, and each case is designed to illustrate a antimicrobial stewardship principle of some sort. So it's not just for Manitobans. Please have a look. There's a pledge you can take to agree to be a good antimicrobial steward. So if you like, please have a look at that, and I'll be referencing this website during the presentation. So the questions for this case: is ciprofloxacin the best antibiotic for Bernadette, or was it, and is it now? And if not, what is the best empiric antimicrobial choice? And can we use a hospital antibiogram in this case to help us inform these decisions? I'll come back to those answers later. And for now, I will turn it over to Dr. Lagacé-Weens.
Oh, you're muted, Philippe.
That's because I'm not actually speaking yet. All right, thank you very much, Terry. And I'll take over here and we'll start talking a little bit about what the antibiogram is. Obviously, one of the important questions that Terry asked was, is the hospital antibiogram useful in this situation? And in order to understand that better, we need to know how they're made. Now, the definition, this wordy definition of an antibiogram as a report generated by the analysis of antimicrobial susceptibility test results from a single healthcare facility over a defined period of time that reflects the percentage of first isolate per patient of a given species, so whether that's E. coli or Staph aureus or Klebsiella pneumoniae, specific species. Sometimes we do organism groups that tells us what proportion of them are susceptible to each antimicrobial agent that we routinely test. Perhaps a more simple way of saying it is a summary of the cumulative susceptibilities of bacteria to specified agents over a period of time at a particular institution, and obviously described as the percentage of those organisms that are susceptible in that institution to that agent. Now, what's very important for everyone to understand is that they are a tool. They're not the be-all and end-all of clinical decision-making. They are a prediction tool that has limitations. And as we go into how they're made, hopefully some of those limitations will be revealed to you. Now, before I talk about these limitations, I want to tell you a little bit about what they're used for. So the main purpose of an antibiogram is to guide clinicians in the selection of antimicrobial agents for empiric therapy for initial infections when the definitive susceptibility test results are not yet available. Most of you will be aware that microbiology labs can only produce susceptibility results in an overnight fashion. So if you get an identification on day 1, you typically don't get susceptibility results until day 2. So it's that window of time that the antibiogram becomes useful. Other uses, though, as an educational tool for prescribers, what antibiotics are useful for what infections. You can use them to monitor resistance trends. So as you do them year after year, you start to see changes in resistance patterns. And of course, to support stewardship efforts. As you start seeing emerging resistance, maybe it's important to address some of these stewardship questions. But it's important to point out that because of the way we prepare these antibiograms, it may not reveal some important trends in emerging resistance. Because we use the first isolate of any infection in a patient, we don't use subsequent infections with the same organism. We are going to miss out on that organism potentially being resistant in that period of time. It's not to say that we can't look at different ways of doing antibiograms that include these subsequent infections, but the way they're usually done is only with that initial isolation. As far as recommendations go to make these things in labs, antibiogram reports should be analyzed and presented at least annually. And in our labs, this is what we try to do because emergence of resistance can happen relatively quickly. Changes in demographic populations happen relatively regularly. And so those should be at least done annually to reflect an accurate depiction of what's going on in that community. Only diagnostic samples should be used. We don't use surveillance samples because they don't really reflect infections, and only final verified tests should be used. That kind of goes without saying. But here's a really important point that everybody needs to be aware of: is duplicates are eliminated. That means that we only include the first isolate of a species from a patient during that analysis period, during that year, for example, regardless of where it was found, what the specimen was, or what its antibiotic susceptibility profile is. So this highlights a very important initial limitation. They are representative of the first isolate of that species isolated from that patient in that year, assuming you're doing a 1-year review, irrespective of body sites. So they will actually undercall resistance in patients with multiple infections. So in that case of that Terry presented of Bernadette with UTIs, who's had recurrent UTIs, who's probably had recurring treatments for UTIs, our antibiogram will probably undercall resistance in that person because we haven't considered the fact that she's not necessarily presenting with an initial infection. So that's a very important first limitation. And just to highlight how big that impact is, here's a study that was done a number of years ago, but it still stands. And in that top table, you have MRSA, so methicillin resistance in patients. If we take the first isolate per patient, it was 60%, 59.1% were susceptible. If you take all isolates in that time period, it drops down more than 15% to 42.2%. So if you're including those patients that have had subsequent Staph aureus isolations, more of them will be MRSA. Not surprising because some of them will have been treated with beta-lactams. Likewise, we see the same sort of scenario with aminoglycosides and Klebsiella, where if you use the first isolate only, about 3/4 of them are susceptible, but only about 6 out of 10 are susceptible if we include all the isolates. So this is an important limitation people need to be aware of with antibiograms, that you need to consider first infection. Subsequent ones is a new piece of information you need to consider in your decision making. Some other limitations you need to consider is that we will only report isolates where there are more than 30 isolates per year, or that we have data for more than 30 isolates per year. So rare organisms cannot have an antibiogram. And if they have less than 30 organisms reported, you really have to be suspicious of those results. And I'll show you some data as to why that is. Now, we can get around this a little bit by combining data from multiple years for that facility, but of course that has its own limitations, that early emergence of resistance might be missed. Second point, another very important point, is that only antimicrobials that are routinely tested for the entire population should be reported. So if you're only reporting an antibiotic or testing an antibiotic for a subset of that population, it can't be put into your antibiogram because it wasn't tested against all organisms. So if you're only doing, for example, ceftazidime avibactam susceptibility on carbapenem-resistant Enterobacterales, we can't report that in our antibiogram because it only reflects carbapenem-resistant Enterobacterales, not all Enterobacterales. So we will only report antibiotics that we test on all of our isolates. And also, we only report the percent susceptible. So percent intermediate or concepts like susceptible dose dependent are not included in that, which you need to consider potentially if you're using high dose antibiotics or antibiotics that are concentrated anatomically, like in urine, where intermediate might not be a big deal, but those will not be included in that definition. Here's an example of why we need to have a minimum of 30 isolate. This is a really busy table, but highlighted in yellow, and red rather, tells you the range of variation that you might see if you have 30 isolates and it's susceptible at 90%. So in this example, Penicillin susceptibility, say, is 90% for strep pneumo. We have a sample of 30 isolates that we're reporting from. The range of susceptibility, just statistically, is going to be somewhere between 74 and 97%. And that's just because we have a low number of isolates. The higher the number of isolates, you see as you go down closer to 1,000, it gets really tight around 90%, 88 to 92. So we have much more confidence in that estimate. So when you look at an antibiogram and you look at the number of isolates that were tested, keep it in mind that this is a range. It's not an absolute number. Secondly, as I was saying, we need to test and report only antibiotics that we test for the entire population. And here you see the impact if you start reporting antibiotics selectively. So in this case, this lab, it's not our lab, it's just an example, only tests amikacin against Pseudomonas if it is resistant to gentamicin, so only tests it in a subset. And you can see that they're reporting that 48% of their Pseudomonas is susceptible to amikacin. But that's a biased sample. It's biased by the fact that you're only testing resistant isolates to gentamicin. If you actually looked at the entire data set, 86% are susceptible to amikacin. So you need to know when you're using your antibiogram how people are reporting it. Is it the whole population, which is the way they should be reporting it, or is there a subset? And you can see here they've tried to indicate it's a subset. N equals 353 compared to 1,356. And they've put a little footnote that says amikacin reported on Pseudomonas intermediate or resistant to gent. But that really needs to be looked at. Just don't look at the number specifically. Some additional factors you need to consider when interpreting an antibiogram is that for strep pneumo and penicillin and cefotaxime or ceftriaxone, we have multiple breakpoints. One is for systemic isolates like bloodstream isolates or pneumonias. One is for CSF isolates like meningitis. And one is for oral penicillin versus intravenous penicillin. So always make sure that when you're using an antibiogram, you're using the correct interpretation or breakpoints. So if you're using penicillin and you're hoping to send your patient home on oral amoxicillin for a pneumococcal pneumonia, make sure you're using the oral penicillin breakpoints, not the systemic ones, which tend to be much higher because the doses we give of penicillin are enormous compared to what you can get orally. And lastly, we always tend to report Staph aureus specifically in two subgroups, MRSA and MSSA, because there are some defined criteria that usually help clinicians assess the risk that somebody is colonized with MRSA. Either they've had a previous MRSA or they have certain risk factors that predispose them to MRSA a lot of the time. And so you can then use one or the other depending on whether or not your patient is at high risk of MRSA colonization. So as you can see here, you don't have the antibiotics, but just to point them out, in the case of methicillin susceptible MRSA, this is clindamycin, so 74% are susceptible, but interestingly, 81% of MRSA are clindamycin susceptible in our antibiogram. Another point about antibiograms is they usually, when they are produced, are facility specific. So the cumulative antibiotic susceptibility is based on local institutional specific data. So ideally, we separate a general report for each healthcare facility we provide services to, assuming we have that minimum of 30 isolates. And it's important that these can vary quite a lot. So if you work out of the Grace Hospital or out of Seven Oaks Hospital, you shouldn't be using the Health Sciences Center antibiogram because it serves a different population with different types of susceptibility profiles. And just to illustrate that with a single easy example, we have our HSC Health Sciences Center in Winnipeg here, antibiogram, Pseudomonas aeruginosa susceptibility of 85% to piperacillin tazobactam, but at the Grace Hospital, it jumps up to 92%. So in one case, a choice might be to use piperacillin tazobactam empirically. In another case, maybe not, and you might want to consider an alternative agent. Not giving recommendations here, I'm just telling you what the data is showing us. What antibiotics we choose to report on antibiograms depends on a number of factors. One, appropriateness. Is that antibiotic good for that organism? Maybe it is, maybe it isn't. We will not report one that shouldn't be used. Is it available on the formulary? We don't tend to report antibiotics that are simply not available at that facility because it makes the antibiogram too complex. Availability of being able to test for those in the lab. Many antibiotics we cannot test for whatever reason, for a number of reasons, or we test them as second or third or fourth line antibiotics so we don't have a complete data set. For antibiotics that are only used to treat UTIs, for example, nitrofurantoin, we only perform the analysis on urinary isolates. So you will not get nitrofurantoin data, for example, on systemic isolates. If there's no data in the antibiogram, the agent might not have been tested, is not on formulary, has no breakpoints, or may not even be appropriate for that organism. So that may be some of the reasons that we have grayed out boxes in our antibiogram. So now that you have a perhaps more complete understanding of how antibiograms are made, I want to talk a little bit about some variations on antibiograms that some people find useful and may be available in your location, depending on where you practice. And these are generally referred to as enhanced antibiograms. And what they do is they do exactly the same thing, but they stratify the data according to other factors. So that could be a ward, that could be a patient subtype, it could be an infection type, so urine cultures versus blood cultures. It could be a clinical service. Your bone marrow transplant service has this antibiogram, but your medicine service has a different antibiogram. So it helps provide additional data on the organisms that you find in your specific settings. Another one that you can do is specific resistance characteristics. Like some labs might produce an antibiogram specific to carbapenem-resistant Enterobacterales to try to give clinicians a better idea of what to use when you have a carbapenem-resistant organism or an ESBL. And lastly, another commonly used one is percent susceptible by organism group. So we pool all of our gram-negative bacilli into one antibiogram. And some people find that useful to provide initial empiric therapy for blood cultures, where your gram-negative is that first result that you get from a positive blood culture compared to the actual identification of the organism, which may take a day or more after that. This is just an example of our own antibiogram stratified by patient population. So here we have at the top the entire Health Sciences Center antibiogram, and at the bottom we have the pediatric antibiogram. And so this is sorry, HSC, no, my mistake. The entire hospital is top, yeah, and the pediatric antibiogram is at the bottom. You can see that there's some substantial differences here. Clindamycin, 83%. And clindamycin 76% in the adult population or the combined population. So this is an antibiogram that might actually provide some supporting evidence for using an oral antibiotic agent for MRSA infections or for Staph aureus infections that might not be supported in the adult population. Another antibiogram here that's from a local reference is stratifying it by patient location. We have one that is outpatient versus inpatient versus ICU and ED. So you can see that, again, this is for Staph aureus, pretty high outpatient susceptibility rates to clindamycin, but they drop pretty precipitously in the other locations. So this is if you're dealing with an outpatient with an initial infection, maybe clindamycin is an appropriate antibiotic, but not presenting in the ICU or presenting in the emergency department in this particular hospital. And then this is another one that's used to provide data on combinations of antibiotics. What proportion of Pseudomonas aeruginosa is susceptible to either ceftazidime or ciprofloxacin? So in this case, it's 86%, or either ceftazidime and tobramycin is 91%. So these kinds of antibiograms are enhanced so that clinicians have a better idea as if they're using combined therapy for Pseudomonas aeruginosa initially to make sure you hit the organism initially. What likelihood do you have to treat the infection with one or the other of these antibiotics in combination? So we don't provide this, but it is one that is sometimes provided depending on your practice location. And here's one that's stratified by organism group as well as body site. So these are all blood cultures, but what you see here is all gram-negatives from blood cultures in Piperacillin tazobactam. Just an example again. But in this case, what it tells us is that when you get that initial result from a gram-negative from a blood culture, you don't know what it's identified as yet. You know that your Piperacillin tazobactam has an 81% chance of being active against that gram-negative rod. That being said, if it's an E. coli or a Klebsiella, it's almost 90%. If it's an Acinetobacter, it's only about 15%. So it doesn't actually tell us at the species level, just a probabilistic tool once you have that initial gram-negative rod result. And here's yet another antibiogram that tells us a little bit about blood cultures, again, so body site, but a resistance mechanism, meaning that if you have an ESBL gene, your probability of being susceptible to ertapenem is 99%. But if you have an NDM gene, it's 0% for ertapenem. And so we have now an antibiogram that can tell us, based on carbapenem resistance genes or ESBL resistance genes, what susceptibility profiles are likely to be encountered in that setting for a blood culture. This is only, of course, useful in a lab setting where those results can be provided to clinicians. What gene does this organism have? And availability of those is still fairly limited outside of certain larger labs in the United States. This slide is just to demonstrate what our antibiogram looks like locally. So all these tables have susceptibility data. You can see some of them are grayed out because they may be inappropriate or we don't have data on them. And these we produce annually and distribute widely to our clinician base. And in fact, I believe all labs should do this. It's a bit of a bone of frustration for me that our local community level laboratories don't provide these to our community physicians, but it's advocacy on my part. And just again, a close-up of one of our tables here that we provide based on species. And in this case, it's largely all of our isolates with a few exceptions because we have E. coli divided by urine and by systemic isolates, which vary, as you can see, in susceptibility on a number of points. But nevertheless, we don't provide stratification beyond that, often because of numbers, and they don't, if you stratify too much, your numbers get too small. In the last few slides, I want to tell you a little bit about how to use the antibiogram now that you understand its limitations and where it can be used. For initial infections, remember these are largely useful for initial infections. We don't have good data saying, what percentage can you use this antibiogram? 90%? Probably 80%, maybe, but there's limited data on how likely you are to make a useful decision based on an antibiogram. So you do need to consider a whole bunch of other factors, not only the percent susceptible, but the infection type. Is it an infection associated with high mortality? If so, yes, like a bacteremia, for example, then you really want to find an antibiotic that has an extremely high probability of being effective. 95? That would be probably a good marker for me. And I don't know if Terry will have other opinions on this. Severity of illness. If your patient is in septic shock, it's very different than if they're stable. The location and infection, so onset. Did this infection happen in the community? More likely to be an initial infection, or in the hospital? More likely to be a resistant infection. What are your possible organisms that we're dealing with if you don't know that yet? Have they received previous treatment? If they've had multiple treatments with antibiotics, those organisms are much more likely to be resistant. That doesn't reflect an initial isolate anymore. Prior microbiology. Look at that patient's prior history. Make sure that they don't have a history of an MRSA infection or an ESBL infection. Obviously, those local susceptibility rates, that's the antibiogram that comes in. Other risk factors for antibiotic resistant organisms. Do they have are they a bone marrow transplant patient? Are they on prophylaxis with antibiotics? Treatment guidelines can also be used, and other considerations, like we all deal with patients who have drug interactions and allergies and side effect profiles that may make one agent more favorable than the other. So antibiograms aren't the be-all end-all. They're a piece of this clinical decision making that we need to consider when choosing an antibiotic. Last utilities of antibiotics I wanted to touch base on. So obviously, making decisions about empiric antibiotic therapy is the big one, but also making decisions on antibiotic formulary. If we have an agent that's quite active, could be potentially useful against our organisms that we encounter in our lab that is not on the formulary, maybe we need to consider bringing it on. If we have an antibiotic that's almost useless because of extremely high resistance rates, maybe we shouldn't have it on our formulary, or at least not for those indications. Making treatment guidelines that are local and specific to certain localities, discussion with physicians, so giving talks like this one, for example, tools to educate clinicians about local prevalence of resistance, and obviously identifying changes over time, which is one last thing I wanted to discuss, is how we can use antibiograms to identify change over time. We have to remember that there's always a confidence interval around these data. So just because you see a number go up or down doesn't mean that there's been a significant change. So obviously, the smaller the amounts of organism tested, the larger that confidence interval is going to be, and the less significant that change is going to be. But when we're assessing for these over time, we also need to pay attention to the opposite. If our numbers are very, very large, we might see statistically significant changes that are really quite irrelevant clinically. So we've seen changes of 58 to going down to 56% susceptible, while statistically significant if you've got over 1,000 isolates doesn't really mean much. But a change from 100 to 95% is actually almost more important because we're seeing the emergence of resistance. So if you were to see your enterococcus rates in blood cultures go from 100% susceptible to vancomycin to 95% susceptible to vancomycin, that means you're seeing the emergence of VRE in bloodstream isolates. So that would be a bad thing for a site, even though that 5% isn't that big a deal from the antibiograms perspective. And that goes back to you, Terry.
Okay, thanks a lot, Phil. Okay, I wanted to come back to the main utility of antibiograms and the Infectious Disease Society of America, the European Society of Clinical Microbiology and Infectious Disease, the Surviving Sepsis Campaign, and countless others all recommend using local antimicrobial prescribing, recommend using antibiograms in local antimicrobial prescribing guidelines. And so we'll focus on that. So I appreciate I might be oversimplifying things here a little bit, but I wanted to take us through how a clinician might be using an antibiogram. So we need to discuss how do we come to an antibiotic recommendation. So first, we'll make a clinical diagnosis, and the clinician is usually doing that, for example, a community-acquired pneumonia. And this includes an assessment, whether explicit or not, of the potential infectious pathogens that may be causing an infection, such as in this case, very commonly Streptococcus pneumoniae or viral agents of lower respiratory tract infection, among other bacterial causes. And I'll be referring to the Manitoba AMR website. However, there are many, many resources across Canada that can be helpful for clinicians to guide them in antimicrobial prescribing behaviors. So Bugs and Drugs, there's First Line, which is an app. The University Health Network has a number of treatment guidelines. And then the BC CDC Provincial Antimicrobial Clinical Expert as well. So the second thing that happens is the clinician will be considering the condition of the patient. So in other words, how severe is the infection, which is another way of saying what is the risk of a severe outcome in this patient. And this helps us to inform many things, including how rapidly we need to act, but also the empiric therapy for the patient. It basically helps us understand to what extent getting our empiric choice wrong in terms of covering a particular pathogen might have an adverse outcome on the patient. For example, we recognize that MRSA may cause a very small minority of cases of community-acquired pneumonia, but in most cases, patients that aren't critically ill or don't have specific risk factors for MRSA, we don't provide that coverage because we recognize that this would expose an unacceptably large number of patients to the risk of either vancomycin or linezolid. So we don't do that. And so you can consider the severity of the patient on the website. We use the pneumonia severity index, but of course that always has to be supplemented by the clinical assessment at the bedside of your sense of how sick they are. And then the third factor that we need to consider is the risk factors for drug-resistant organisms. So even before we got to the antibiogram, we need to think about, does this patient have a history of colonization with drug-resistant organisms? Have they had recent systemic antibiotic uses? Have they been hospitalized or are they hospitalized? And have they had travel to high-risk areas for drug-resistant organisms? And I've just put this slide up here to remind us that travel to specific regions, such as South Asia, is a risk factor for drug-resistant pathogens. So that needs to be considered as well. So finally, we can look at the institutional antibiogram data, and Phil has already taken us through that. But if we're considering pneumonia, then we obviously want to look at the in vitro activity against Streptococcus pneumoniae and consider that in our antibiotic selection. So ultimately, as a clinician, we need to consider all of these factors. And some more, including allergies or pregnancy that may preclude the use of certain agents in making a choice to prescribe the optimal antimicrobial treatment. And so our goal is to sort of toe the line between choosing an empiric therapy that will be clinically effective and safe for the vast majority of cases, but without being so broad as to expose many patients to the undue risk of adverse side effects or potentially also increased risk of drug-resistant bacteria in the future due to overly broad antimicrobial prescribing. And so then we can look at, again, this is a local guideline, but based on risk class, based on some risk factors for drug-resistant pathogens, based on severity and other considerations, we can choose the optimal antimicrobial therapy. So that's how we might conceptualize using an antibiogram in clinical practice, but are they primed for clinical use? So as I mentioned, many guidelines advise using antibiograms to help guide therapy recommendations, but antibiograms have many limitations that have been discussed. And these include that they do not generally incorporate patient-level information or risk factors. And so that's a huge limitation of antibiograms, and they just weren't designed to do it. In addition, in our antibiograms, certain high-volume clinical areas may be overrepresented. So that the antibiogram takes the first clinical isolate for a particular organism for a particular year at an institution, but does not consider necessarily where those are all coming from. So if there's an overrepresentation, and many of these are coming from the OR or from a specific clinical area, those will be overrepresented, and we don't have any way of assessing that when we're looking at our antibiogram. There's also an extreme paucity of data on the predictive accuracy of antibiograms for helping us guide our antimicrobial choice. So briefly, I want to discuss one study that tried to look at this predictive accuracy. So in December 2023, the University of Iowa researchers published a study trying to get a sense for the predictive accuracy of antibiograms. They used a very large data set, which was the Veterans Health Administration data from across the United States VA hospitals. And so they used antibiogram data that was stratified to the facility level to the most recent calendar year. And all of these hospitals used CLSI guidelines for the identification of resistant isolates and the creation of antibiograms. So their cohort included 127 hospitals, and they were aiming to assess the predictive accuracy of two bacteria, E. coli and Klebsiella. So they generated these antibiograms using all of the methods that Phil described. And then for the patient level data set, they basically excluded any patient that had a positive culture with the same organism that we were trying to predict within a previous 12-month period, because they assumed that clinicians would just use those results from that patient as opposed to the antibiogram. So if you had an E. coli that was resistant to ceftriaxone in the previous 12 years, you're not going to use the antibiogram to help you decide if the patient should receive ceftriaxone. You're going to look at that previous isolate and say, yeah, no, they had a resistant isolate, we were not going to use it. And then they basically compared all the new isolates in a particular facility to what the previous year's antibiogram would have predicted as being susceptible for this patient level data set. And then they constructed 2x2 tables of sensitivity and specificity and then used receiver operating curves for all the antibiotics, which was effectively the primary outcome. So at the end of the day, what they found was that they had hundreds of thousands of specimens in the patient level data set for both E. coli and Klebsiella, very large data set. And you can see the breakdown of the isolates that were coming a lot from urine, which makes sense, they're gram-negative rods, but from a smattering of other sources, including blood. And you can see here sort of the proportion of susceptible isolates in the facility antibiograms, which is not terribly dissimilar to what we might see in Canada for these gram-negative rods over the study period. And so what they saw was that the patient-level antibiograms had a generally poor predictive value for predicting antimicrobial non-susceptibility. And so if we choose an interpretation threshold with a reasonable sensitivity cutoff for antimicrobial non-susceptibility, such as let's say an 85 or 90% sensitivity for that antimicrobial, then we end up with a unacceptably low specificity, like 10% or thereabouts. And I'll show you this slide here. It's quite a challenging slide with a lot of data. And I think I had to read this slide about 6 times to fully understand what all it was saying. But basically, the sensitivity in this case is how well the antibiogram threshold above a particular value predicts a susceptible isolate. And then the specificity is how well the antibiogram threshold below that value predicts a non-susceptible isolate. And so essentially what we're seeing here is that if we were to try and pick a reasonable sensitivity of, let's say, 90%, the specificity becomes quite poor, like around 10% or less in most cases. So ultimately, at the end of the day, the antibiograms performed very poorly or relatively poorly at by themselves at predicting antimicrobial susceptibility for any given agent. So the author's conclusion is that we need to reconsider their use in clinical practice as they stand. And as far as using antibiograms in isolation for helping us pick an empiric antibiotic choice, I agree. Using an antibiogram as the only tool to help us pick an antibiotic is a bad idea. They're important, and it's true that their importance in bedside decision-making may be overestimated. We need to consider the clinical history, and we need to think about the risk factors for a particular individual for drug-resistant organisms. However, I think it's premature to completely dismiss antibiogram data. As mentioned, stratified or enhanced antibiograms may do a better job, and they may have a better diagnostic accuracy. So this could be, according to the clinical setting. So, outpatients versus inpatients versus ICU, according to clinical syndromes or particular patient demographics, such as elderly or pediatrics. That may help. But at the end of the day, what we really need to do is start making efforts on the research side to think about how we can use all this data that's included in the antibiograms, and also start to incorporate clinical data to help us come up with better predictive tools to help clinicians. And I think this is potentially an exciting area for the future. I mean, I think that there's a lot of work left to be done here. Machine learning might be able to help because there's ultimately, if you're trying to simulate an expert level clinician who can incorporate antibiogram data, risk factors, and local guidelines, you're going to need a lot of data to include and help us generate these better tools. So coming back to the case study. We've got Bernadette, who now has gram-negative bacteremia with E. coli in the urine and blood from pyelonephritis, and she's not doing better on ciprofloxacin. So what we want to do is take a further history regarding her recurrent urinary tract infections. Has she had recent antibiotic? Has she been spending time in hospital? Has she been traveling to areas that might have higher risk of drug-resistant organisms? And most importantly, I think in this case would be, has she had previous cultures that can help us guide, what a prediction of her current antimicrobial resistance profile on E. coli might be. We know that a very, very powerful predictor of future drug resistance is a recent isolate. So especially in the last 6 months, but even up to a year or more, is to think about the recent microbiology that she may have had from the urinary tract and use that to really help us guide what would be the best therapy. But assuming we don't have that, this Bernadette is moderately ill with pyelonephritis. She has some risk factors probably for increased risk of drug-resistant bacteria. And appreciating the limitations of the antibiograms, the goal here is to pick an agent that is that will cover her E. coli in 90% of the time. Or we can argue about that, but essentially, most of the time, but without being overly broad. And in this case, however, she, ciprofloxacin at the local facility level has an antibiogram for E. coli showing only less than 60% as being susceptible. So probably this is not an appropriate empiric agent, especially given how ill she is. On the other hand, perhaps the previous day an oral agent such as amoxicillin clavulinate may provide a more reasonable sensitivity with a antibiogram susceptibility around the 80% mark. At this stage in the game, if she's unwell, she's probably going to wind up on IV therapy, and we'd likely choose an agent given her risk factor like piptazo, piperacillin tazobactam, or even a carbapenem like meropenem. Appreciating it is overly broad, but she's got risk factors, and we have high institution-specific resistance rates to other first-line agents for pyelonephritis. So ultimately, that's how we might incorporate the antibiogram data. So in summary, antibiograms are a summary of cumulative susceptibilities of bacteria to a battery of antimicrobials tested in a particular institution on a first isolate over a period of time. And they have a limited clinical predictive capability when they're used on their own. They may supplement the bedside history, but the assessment of drug-resistant organisms is critical. We need to know their limitations, and we have to appreciate that they don't consider any patient-level factors whatsoever. That is it.
Thank you, Terry. Thank you, Philippe. Wonderful presentations, and really give us much more balanced, nuanced understanding of the antibiogram and its place. We want to go to the Q&A now. We have lots of questions ramping up here. So going to the Q&A pod, I'll just take these in order. I'll just voice them for you here. What is the rationale from CLSI for only including the first isolate per patient per reporting period, even when the susceptibility profile has changed in a subsequent isolate? Is that one for you, Philippe?
Yeah, probably. I mean, the rationale is that it's fairly simple, I suppose, is that the antibiogram was designed to answer a specific question of what is the first isolate susceptibility profile on average. It's not to say you cannot create antibiograms that are different. Some sites may create antibiograms that are actually specific to subsequent infections, so excluding the first entirely and only considering the second or subsequent ones. The downside of that, obviously, are two. One, you're going to exaggerate resistance levels for individuals who have a first isolate or first infection, and you're also going to reduce your numbers dramatically because it's a fairly small number of individuals who have subsequent infections, and you may not meet the criteria you need to get sufficient numbers to produce an acceptable antibiogram for most organisms. So it's not to say that there's a rationale for one or the other. It's just that it's the one where we know we have the most numbers that can answer the most common question in a way of, you've got a patient that comes in, they haven't come in the past year, they have a urinary tract infection. What is the likelihood that that organism is susceptible susceptible to X, Y, or Z antibiotic. So when we look at enhanced antibiograms, we can start parsing out that information and making it perhaps in a way, as Terry was saying, more useful in specific situations. So do we need to have antibiograms for subsequent infections? They may serve a purpose, and it's not to say that CLSI excludes that as a possibility, but we're going to have very small numbers and a very limited data set, which may not be as useful.
Okay, thank you. I'm going to move us on to the next question, as we have a few to get through. What is the rationale? Oh, sorry. How useful is using antibiograms for stewardship efforts outside of acute care facilities, in community clinics, for example, or correctional facilities, where the entire population isn't as specific as a hospital? Maybe that's as well something. Can you comment?
Well, I can certainly comment. I don't know if Terry want to add anything. Minimally useful, I would say, because as I said, antibiograms reflect a specific location, a specific hospital, a specific facility. That's not to say that you can't produce antibiograms for a community or can't produce antibiograms for, in this case, a correctional facility, should they have sufficient numbers to reflect that. And we absolutely do create, as best as we can in our labs, antibiograms for community regions that we serve. But you can't, once you get into such small areas that they only get a dozen or so Staph aureus isolates in a year, we can't provide data on that. There's just not enough. So really, it depends on what you're being provided with. If the data is specific to your community location, then it could be useful for stewardship purposes. If it's not, it would probably be very minimally useful.
Right. Terry, did you have anything to add there?
Yeah, no, I mean, basically, at the best, in the best case scenario, an antibiogram is reflective of the population from which the data was taken, right? So if you're taking hospital patients and creating an antibiogram, then using it for community, community level interventions for stewardship, like that's probably not appropriate. And even when you're using it from, in the population from which the data was taken, like there's just major limitations that we have to recognize. So always keep that in mind, that it's just one piece of data among many that need to be considered.
Thank you. Now we have a question about smaller sites. Can smaller satellite hospitals that participate in the development of antibiograms by providing isolates feel confident in using the antibiogram provided by a larger linked hospital or facility?
It's a very similar answer to the last one. Generally, it would not be as reflective of their experience or their isolates. That being said, we do provide antibiograms to specifically smaller satellite hospitals. I mean, as an example, Boundary Trails here in Manitoba is a smaller rural hospital that provides sufficient isolates for us to analyze, and we do provide them with an antibiogram. So it really depends on the practice of the lab that you send these isolates to, but we do tend to stratify them by specific smaller regional hospitals if we can. But if it's all being amalgamated into one big antibiogram for that entire lab, I would say that that is not predictive of a smaller hospital's experience.
Right, right. And there's maybe a clarifying question about, are the antibiograms using all the regional data, inpatient and outpatient, or just inpatient? Is that a clarifying question?
Yes, and yes, it depends on the antibiogram. So we produce antibiograms that can be very, very specific inpatient ward. If we have enough isolates, we don't do that locally, but some hospitals do, or very broad, like the entire tertiary care hospital data.
Okay. And maybe can you help me understanding this question? Would these be similar to the sensitivity report? I suppose these being the antibiograms that is listed when an organism is found
So
on
this, I'm glad somebody asked this question because it's a very important distinction. So a sensitivity report is specifically that one organism that was isolated from that one patient. So it's very different than an antibiogram. An antibiogram is a cumulative susceptibility of all of the organisms of that species that were done in that location as a percentage of probability. So for your specific organism, organism from a culture, that one organism is sensitive or resistant to ciprofloxacin. That relates to that one organism, whereas an antibiogram tells you 63% of our E. coli strains that we get in this entire region are susceptible to ciprofloxacin.
Right. Yeah. I'm just looking at some of the range of questions here. We probably have time for one more question. Do either of you want to select a question from our list that's maybe not covered? Well, just looking at maybe how far back in the patient's history would you recommend looking for resistant organisms?
That sounds like a Terry question.
Yeah, I think that I mean, the more proximal in terms of time, the better. So it's more of a sliding scale, I guess. But I always look at, like, I certainly consider, anything in the last year as being highly more predictive. And then beyond that, increasingly less so. If they had an E. coli producing ESBL producing E. coli from 6 years prior, probably not super relevant. Yeah, so I certainly within a year is a good thing to do. And maybe and I look back further, but I just consider them less strongly. Yeah.
Okay,
And
thank
there's
you
a
both. Yeah,
there,
sorry.
well, there's a question here. Does the hospital antibiogram based on first isolate, is it not likely representing community antibiogram as well? And I want to answer that one because I think it's an important one. And the short answer is no, because a lot of our infections are onset in the hospital. So may have been individuals that are colonized by hospital pathogens. So your multi-drug resistant gram-negative rods, even though they are nosocomial infections, they will still represent the first isolate for that patient. So it will be skewed towards, to some extent, the hospital-acquired infections as well.
All right. Thank you for those answers. Thank you for your questions. I apologize we've run out of time. This has been a wonderful, wonderful event, and I really appreciate Terry and Philippe for taking the time. Join us back on April 14th for a webinar focused on penicillin allergy delabeling. So save the date. Registration is not quite up yet, but it will be. And you'll look at the AMR, AMR Aware Canada website for news of upcoming events. And here, I really hope you'll take a moment to complete our survey. Let us know how we did. Give us some feedback, and it really helps us shape the events in the future. So take a picture of the QR code and jump on to the evaluation to finish that. And we will be posting a recording of today's webinar on the AMRaware.ca website and posting it to YouTube account. So please tune in again for more events in the series. This has been a wonderful event. I thank you both for participating in such an integrative presentation today. Thank you all, and thanks everyone today for joining us.